My name is Lisa Newman. I am a surgical breast oncologist. I am chief of the breast surgical section for Weill Cornell Medicine in New York City, and I am director of the breast program for the Weill Cornell Medicine New York Presbyterian Hospital Network, covering hospitals in Brooklyn, Queens, and Manhattan. I also have the honor of serving as a medical director and founder for the International Center for the Study of Breast Cancer Subtypes. My career is focused on managing breast cancer, and we've made some wonderful advances in the field of breast cancer in terms of improving outcome through improvements in all of the disciplines that we bring together to manage our breast cancer patients. We've made improvements in the surgical management of this disease. We've made improvements in the medical therapy for breast cancer, in the radiation therapy for breast cancer. We've even made huge advances in our ability to detect and characterize breast cancer through breast imaging and also through pathology. None of these advances would be possible without research. Research is critical to make improvements in breast cancer management because we need to be constantly identifying newer strategies that can evaluate this disease better and make patients live longer despite having had a diagnosis of breast cancer. These efforts have been effective thus far, but it remains true that far too many women continue to suffer from breast cancer, and far too many women die from breast cancer. A lot of the research that I am personally involved in looks at trying to characterize the genetic explanations for these types of disparities. And what we've been learning is that indeed there are some genetic features related to African ancestry in and of itself that predisposes African American women to biologically aggressive patterns of cancer, such as the pattern known as triple negative breast cancer. My research team does a lot of work in Africa, where we are looking at the breast cancer burden of women that live in Africa, and we are comparing the breast cancers of women from Africa to the breast cancers that we see among African American women. And we've actually identified some really fascinating findings. We have indeed identified the fact that there are specific genetic patterns linked to Western Sub-Saharan African ancestry that seems to be driving this higher risk of biologically aggressive breast cancers, such as triple negative breast cancers in African American women. The transatlantic slave trade from several centuries ago brought the ancestors of contemporary Western Sub-Saharan Africans across the Atlantic Ocean to serve as slaves in the colonies. And so as African Americans, we actually have a lot of shared ancestry with contemporary Western Sub-Saharan Africans. For patients that are already diagnosed with breast cancer and are in the midst of getting their breast cancer treatment underway, my best advice to you is to be frank with your physicians, honest with your physicians, open with your physicians about inquiring regarding whether or not you are indeed a candidate for any clinical trial opportunities, any clinical trial options. If a patient feels that their cancer treating provider, their cancer treating team is not giving them adequate information regarding clinical trials, or if they get the impression that their clinical team is simply not giving them adequate responses or doesn't feel comfortable discussing clinical trials, then that might be a clue that you need to seek an additional opinion or look for your treatment opportunities elsewhere. Healthcare inequities, and unfortunately, it is true that our healthcare system does suffer from inequitable treatment delivered to women of different socioeconomic backgrounds, women of different racial ethnic backgrounds. These types of healthcare inequities do exist in our system because of systemic racism that pervades all aspects of society, including the healthcare delivery system. I want to remind these women that participating in a clinical trial is actually one protection against suffering from healthcare delivery system inequities. because participating in a clinical trial not only means that you might be able to receive some novel, promising agent more quickly before it becomes widely available on a commercial basis, but it also means that your management in the context of clinical trial participation is going to be very tightly regulated and monitored. If you are not a candidate to actually participate in a clinical trial related to your treatment, you may well be a candidate to contribute to a clinical research biorepository, which won't affect your cancer treatment at all, but it will provide you with an opportunity to contribute to information that we are going to be learning about breast cancer, which will be helpful for patients in the future. Agreeing to contribute to biorepositories enables researchers to compare your breast cancer treatment experience and your breast cancer patterns to the patterns of other women so that we can learn about some of the drivers of lesser aggressive versus more aggressive tumors. I absolutely and passionately encourage women out there, if they are diagnosed with breast cancer, to connect with the advocacy community, to organizations like Tigerlily, organizations that do tremendous work in connecting women to research organizations, research cancer programs, research physicians, clinical trialists. These organizations are wonderful about establishing these connections. Please do continue to support and advocate on behalf of research funding through the federal government, through local opportunities, and through philanthropy. It all counts.